I will be talking about National Leprosy Eradication Program, which is one of the health programs under National Health Programs. So we will be talking about that. So it is one of the infectious disease which is caused by Mycobacterium leprae, and this primarily affects the skin and peripheral nerves, and there's a stigma behind this disease. If you find anyone having this disease is very stigmatized, and then they correlate it with curse given by God and many other things in the society. So it is one of the ancient diseases which goes way back in 1400 BC, which is very evident from the Egyptian sculptures. And Indian society also, if you go back in 16th century, you can see mentioning of disease in India and China. And then as per Vedic writings, this disease is known as Kushtaroga, which is equivalent to leprosoria for isolation. Leprosy is also known as Hansen disease because Hansen was the scientist who recognized or who discovered the causative organism Mycobacterium leprae. So the if you will read further, there is a vial which is Cholmugura vial, which is supposed to have anti-leprosy effect, and this was used for the treatment. So as per the current status, I think this is 2-3 years previous year's data, 2021 nearby. So throughout world, only 3 countries in the world are having leprosy cases. The first and foremost is India, which is accounted almost 67% of cases, and then Brazil 12%, and Indonesia. So only these 3 countries are having leprosy cases throughout the world. And then if you will see grade 2 deformity in these new cases, so India is having 43%, 15% in Brazil, 12% in Indonesia. So this is 2017 WHO world picture, which is showing the leprosy new cases detection worldwide. So either you will see not reported or 0. In light blue, little dark, 1 to 99, and then further it goes. So you can always refer when I will share that. So India is having more than 10,000 cases. Then Brazil is the second one, as I said, and then the Indonesia, the third one. So annual leprosy report from India. This is 2017-18 data. So prevalence rate is 0.67 per thousand population. Even though prevalence rate is 0.67, but because we are a populous country, we are having largest population, one of the largest population in the world. So when it comes in numbers, it looks very big. And annual new case detection rate is 9.27 per 1 lakh population. And if we will see grade 2 deformities, that is 3.34 per million population. And then 34 out of 36 states and union territories has already eliminated leprosy, except Chhattisgarh and Dadar and Nagar Haveli. So the states which are showing prevalence rate less than 1 per 10,000 population are Bihar, Chandigarh, Odisha, Goa, and Lakshadweep. So altogether, 128 districts out of 682 districts are having a prevalence rate less than 1%, less than 1 per 1,000 population. So this is prevalence rate in India as on March 2017. So you can see states like Chhattisgarh, Odisha, and Bihar, they are having No, they are little darker, so they are having more number of cases, more prevalence rates. Just graphs which you can refer. Okay, so India is doing national sample survey to assess the new cases, disease burden of leprosy in India. This is done through there is an organization called National Jalma Institute of Leprosy, which is situated in Agra, and Government of India does this sample survey in collaboration with Jalma. Jalma is also one of the pioneer institutes for TB, which we will be discussing later on. So this is a partnership between ICMR and National Leprosy Elimination Program. This is done to estimate the new leprosy cases grade and grade 2 and to assess the magnitude of stigma. Cluster-based cross-sectional survey for last how many minutes you lost me? Hello.
Mm. Just now.
Okay.
Mm-hmm.
Okay. So when this survey was national sample survey was done by Jalma. So as I said, 14 crore 72 lakh 1 crore 47 lakh 25,525 people were screened, and then in that sample survey 2,161 cases were found, out of which 1,300 were paucibacillary and 861 were multibacillary. So this new case estimates were supposed to be 3,30,346 cases on the basis of screening. There was an estimate which was being calculated. So as per this survey, 3,30,346 cases were still in India.
Excuse me, sir. Your
Yeah.
screen is not sharing.
Okay.
Mm-hmm.
You can see now. Okay. So so the estimates were calculated, and the estimates were supposed to be 2,161. Estimate was supposed to be 3,30,346 cases, and this sample survey says that the stigma because of leprosy has reduced compared to before. So the epidemiological determinants. So as I said, leprosy is caused by microbacteria leprae. The environmental factor can be poverty, and then infected person can be male. So this disease affects more male. compared to female. And then overcrowding can be one of the environmental factor. Migration can be one of the environmental factor which can lead to disease. This is spreads by respiratory droplets. Tattooing and intravenous drugs are the risk factors. So the clinical factors, this is characterized by hypopigmented area, patches, loss of cutaneous sensations because this affects primary peripheral nerves, presence of thickened nerves, and presence of acid-fast bacilli in the skin or nasal smear. So the classification. So there are multiple classifications which are readily available. WHO classification, Ridley Joplin classification, Indian classification, Madrid classification. So multibacillary and paucibacillary is the very widely used classification. So any person who is having less than 5 patches or equal to 5 patches with or without nerve involvement is having multi-bacillary, and more than 5 patch less than 5 patches and more than 6 patches are supposed to be paucibacillary. As per Ridley Joplin classification, it is divided into tuberculoid, borderline lepromatous, and pure neurotic. So these are the classifications which are being used. And then the complications because of leprosy, you can see deformity in limbs, or the person loses their finger on its own. So you will see amputation is something when the limbs are being cut down. Whereas in this disease, you will see automatically because of this disease, the person starts losing its finger, losing its ear, losing its nose, something like that. And then you will see tropical ulcers on the body. It can have corneal ulcers, which can lead to blindness, saddle nose deformity. As I said, you will see the the nose getting flattened or something like that. Mydriasis, and then in male child dysfunction and infertility. So WHO has graded disability because of leprosy. So in eyes, if it is normal, then 0. Weak corneal reflexes, then 1, and then lagophthalmos, and then 2. In hands, 0 for normal. If there is a loss of sensation in palms and over the palms, then it is 1. And then if you can see visible damage, as I said, the fingers are getting loss of finger, or then clawing of hand, then it is grade 2. In feet, if there is nothing, then normal. If there is loss of sensation over soles, then grade 1. And then visible damage or loss of toes, or there is something called foot drop, then this is grade 2. So the treatment guideline. So multiple drug therapy is used for treatment of leprosy. So for paucibacillary, there is some different line of treatment. For multibacillary, there is a different line of treatment. So basically, the drugs used are rifampicin, clofazimine, dapsone. So these are the drugs which are used for the treatment of leprosy, and the doses are over there, which you might refer. But this is not much required when you are dealing with program. So rifampicin is used for curing single lesion. So that is possibly for paucibacillary leprosy. If you will see historically leprosy, so previously leprosy was known as National Leprosy Control Program, and then gradually it was recognized as Leprosy Elimination Program. So before 1983, this program was known as National Leprosy Control Program. At that time, government focus was to control the leprosy. 1983 onwards, Government of India started calling it as National Leprosy Elimination Program. So, as I said, if you will see historically milestones in 1898, Leprous Act was abolished by British India. 1948, Hind Kush Nivaran Sangh was established in India. 1945, NLCP, that is National Leprosy Control Program, was formed. MDT, multiple drug therapy was identified in 1970, 1982, multiple drug therapy, the three drugs which I discussed in previous slides. 1983 National Leprosy Eradication Program came into. 1991 WHO declaration to declare to eliminate leprosy globally at global level by 2000. And then 1993, the World Bank started supporting NLAP, National Leprosy Elimination Program, Phase 1. So 1993 to 2000, this was sponsored by World Bank. Then again, Phase 2, that is 2001 to 2004. This program was supported by World Bank. In 2005, India eliminated leprosy at national level. Okay, so remember, eradication is something else, but uh, we are still having cases which are found in India. So in 2016-20, Global Leprosy Strategy was formed, and in 2023, India came up with National Leprosy Strategy Program, which I will be sharing in this group. So there are multiple institutes which are involved in anti-leprosy activities throughout India. So first one is Central Leprosy Teaching Research Institute, which is situated in Tamil Nadu. The place name is Chengalapattu. Then there is Regional Leprosy Training and Research Institute, which is based in Raipur, Chhattisgarh. Regional Leprosy Training and Research Institute, Gauripur, which is based in West Bengal. And then international agencies like ILAP, SIDA, Dandia, WHO, UNICEF, Damien. These are throughout India, they are supporting government in some or the other way to overcome leprosy cases. So this is how the leprosy institutes are placed in India. So NLAP program. So started in 1983 under Ministry of Health and Family Welfare. This is 100% centrally sponsored program. So this became a centrally sponsored program in 2005. Before that, this was funded by, again, funded by World Bank, but taken care by Government of India. So this is headed by Deputy Director General of India. The international agencies which are supporting in National Leprosy Eradication Program are ILAP, SIDA, Dandia, WHO, and Damien Foundation. Anyone knows what is ILAP? Anyone is aware about that? International Federation of Anti-Leprosy Association. So ILAP stands for that, which is, and SIDA is Swedish agency. Dandia is Danish agency, WHO you all know, and UNICEF you all know, and Damien Foundation is again a global organization which helps. So this picture which you can see in the right side is emblem for NLP, which consists of lotus, which is symbol of beauty and purity. Leprosy can be cured. This shows that leprosy can be cured. Partial affected thumb and normal forefingers, which is holding the lotus. This shows that leprosy patient can be useful member of the society. And the rising sun, which you can see across the fingers, this is symbol of hope and optimism. So NLP objectives. So the objectives are to eliminate leprosy in all districts. So this is talking about elimination. So previously we have eradicate it. So the second objective is to strengthen disability prevention and rehabilitation, and the third one is to reduce stigma. As I said, this is having a lot of stigma. So government of India aspires to reduce the stigma. Can anyone tell me what is difference between eradication and elimination? Anyone?
Eradication means to remove completely,
Okay.
and eliminate just to remove a part of it.
Okay. So eradication is zero cases. Okay. Elimination is something where we are aspiring or we are trying to reach zero. So there is a predefined number. So if we achieve that, so we say that we have eliminated. Whereas where there are zero case reporting throughout, so WHO says throughout 3 calendar years. So this is supposed to be eradication. So don't get confused. So if one place we are talking about eradication, one place we are talking about elimination. So don't get confused. So this was to just clear out that. So the components of National Leprosy Elimination Program are case detection and early management, disability prevention and medical rehabilitation, IEC and GCC, human resource capacity building, and program management. So there is decentralized integrated leprosy services throughout, at every level you will see. So early detection and complete treatment of new leprosy cases, household contact survey in detection of multibacillary and child cases. So if there are there is a identification of multibacillary cases or a child who is having leprosy, then household contact survey. So all those people who were in contact with that child or that case are being no they are being screened, so whether to see whether they are also suffering from leprosy. So involvement of ASA for leprosy work, strengthening of disability prevention and medical rehabilitation, and then IEC activities, self-reporting to and then reducing IEC activities are targeted towards sensitizing population, so that if they come across this sign and symptoms, they will go and themselves report at a PHC or at a hospital. And then the IC activities are targeted towards reducing stigma towards leprosy in the community. So intensive monitoring and supervision is one of the strategies which is adopted under this program at PHC and CHC level. So this is somehow the organogram under National Leprosy Eradication Program looks like. So there is a state, this program is supported by WHO. So there is a state coordinator, and then there is a medical officer at district level, and then there is a state leprosy officer which sits at state level, and then above state. As I said, this is centrally sponsored program, and there is a central leprosy division. Similarly, there is central TB division. So all verticals, they have a division over there at Delhi under Ministry of Health and Family Welfare. And then down there is a district, at district level, there is a chief medical officer. Then it goes further down, and the lower level you will see ASA and Anganwadi worker are responsible under this program. So urban leprosy control program was started in 2005, and so to because there is a rapid urbanization, and then you will see overcrowding, poverty, and then sanitation and hygiene is not that good. So that's why government started this program in 2005, and then in 4022 urban areas this program is being taken care, and then This is all these 422 identified urban area is having a population size of 1 lakh or more than that. So urban areas are grouped into 4 categories: township, medium cities 2, mega cities. So the performance of elimination program. So the monitoring is done under four headings: case detection, drug supply, IC activities, and management. So this is being carried out by this monitoring is carried out by National Institute of Family and Health and Family Welfare, which is situated in Delhi, Munirka. So every year in 12 endemic states, this is done for 3 years since 2005, 2002. So the slogan of this elimination monitoring is prevalent. Prevalence rate to be reduced to less than 1 per 10,000 population. So indicators of this program monitoring are prevalence rate, new case detection rate, treatment completion rate, disability proportion, multi-bacillary cases, and child proportion. So because a child, if you can see in previously also, if there is a detection of child cases, so they will see for contact cases. So if there is a child case, then they are suspecting that some elders in the family also are having that leprosy sign symptom. So records and reports under NLAP at PHC level or primary care level. So every patient is having a patient card. So PHC treatment record is being maintained at the PHC level. Then there is separate leprosy drug stock record, and there is a monthly reporting format for National Leprosy Eradication Program. There is a disability register form. There is assessment of disability and nerve function, a referral slip form, and prednisolone card, whether the patient is being on prednisolone or not. So these are the cards. If you will see disability register, this is how it looks like. Then newer updates. Okay, I will be sharing one document which you will go through that. This is the document. So this is, as I said, in 2023, government came up with National Strategic Plan and Roadmap for Leprosy. So there are multiple things, and then government has added upon the existing program how to strengthen it further. So if you will see, there are multiple prongs which I will discuss. Yes. So, so the strategic pillars under this program are strengthening, accelerating, providing quality services, prevention of diseases, and digitalization of the program. So this I will share now over here in the group. Okay, I will be sharing it once I will complete that. Okay, you should know about NICUST. NICUST is a online reporting system with patient tracking mechanism, and this is supported by National Informatics Center, which is being taken care by Government of India. This is for early data analysis, and if there is any prompt action required, then the message is sent to the individual's PHC where that patient is registered, so that medical officer can take action at its level. And then if this is all with having latitude and longitude, so these all cases are GIS mapped, and so that we can know that where these leprosy cases are distributed. Mhm. Okay. So there are multiple things which are not required at your level in this slide, which I will remove and share it with you guys. You guys are having any questions, then you can ask. Otherwise, I am done with the session for the day.